Welcome everyone. Welcome to the next Covidsurg webinar, which is going to look at pre-operative isolation. It's not that often we get to release a paper that will affect everyone undergoing surgery across every specialty. And so this is a unique moment to change things for all of our patients around the world. So thank you very much for joining us. What we're going to do today, I'm joined by a global panel who I'll introduce in a moment. We're going to do a presentation of the core of the data. And then what we're really going to do is discuss the weaknesses and then the strengths of implementation of the data, because this is a direct take-home type of paper, and it's the front lines that are going to change this. So Joanna Simoish is a research fellow and surgical resident. So she's doing a PhD in global surgery at the University of Birmingham, and she was the lead for this study. And she's currently on holiday in Portugal. So not on holiday, that's home for her. So she's on holiday at home. Thank you for joining us.
Thank you.
Janet, Martin and I have been collaborating on our global surgery work for some years now. And Janet is faculty in anesthesia and perioperative medicine and a clinical epidemiology researcher at the Western University in Ontario, Canada. So Janet, you're not a surgeon, you're coming at this from a different angle, but it's a pleasure to have you here today. And Anna Minaya Bravo. Anna and I have collaborated for nearly a decade now on our European cohort studies and our global cohort studies. And Anna's contributed, I think, to all of those. So she's a central collaborator to those studies. And she's a colorectal surgeon at Henares Hospital in Madrid in Spain. Hello, Anna, and thank you for joining us today. Don't worry, I think we were just muted for a moment. So we're going to look at preoperative isolation on post-operative complications in elective surgery patients. So this is one of the strategies that I think globally we brought in to protect patients and protect patients in hospital, but there's no data behind it to show whether there's a very strong benefit or to show whether there is not a benefit. And when we started on this process, we really didn't know, but we're going to release that data today. So Joanna, I'm going to pass over to you. Joanna's going to present the study design and the data, and then we can ask questions. So if you've got any questions from those listening today, please do fire them through and we will answer them as we go. So Joanna, share screen and over to you, please.
Thank you very much, Anil, and thank you everyone for being here with us today. So I'm going to give you an overview of the findings of the study, and then we're going to crack on with some intense discussion. This paper focused on the effects of preoperative isolation on post-operative pulmonary complications. And why is this an important question to be answered? We know that a perioperative SARS-CoV-2 infection is harmful for patients. There is a high mortality and complication rate associated with that. And we also know that there are a few strategies in place to reduce and mitigate the risk of a SARS-CoV-2 infection around surgery, and to mitigate the risk of asymptomatic carriers to be operated and have the consequences of such infection, and also to give the infection to other patients that are in the hospital. And those strategies have been preoperative testing, vaccination, and also something that has been recommended from different institutions and societies in many countries, which is preoperative isolation. The evidence behind preoperative isolation hasn't really been formulated to support this strategy. So preoperative isolation has been in place in many settings with an intent to reduce the chance of patients getting a preoperative SARS-CoV-2 infection, but we also know that preoperative isolation leads to patients being more exposed to other things. Let's say patients usually say that they feel that they can cope differently with anxiety and depression before surgery because they don't have their usual social support. They might eat differently, they might not have the same level of physical activity, and there are a few other things that can influence their outcomes as well. So we have conducted an international prospective cohort study to address a few COVID-related questions for surgical patients. And this is basically a pre-planned analysis of the Covidsurg Week study. This study included patients undergoing elective surgery in any hospital in the world, any surgical specialty, and the data was collected in October 2020. Each hospital was invited to take part for a period of 7 days, but many hospitals took part for longer than that, but only during October 2020. We have defined preoperative isolation as a limitation of social contacts before elective surgery, and that included patients staying at home, avoiding public spaces and public transport, and also not receiving visitors from outside the household. The study outcomes that we're going to look at today are the main outcome, which was postoperative pulmonary complications, and also 30-day mortality and 30-day SARS-CoV-2 infection after surgery. We have designed a subgroup analysis and sensitivity analysis to answer other few questions that might come to your minds. So, is isolation worth doing only in a group of patients, only in a particular setting? And we've tried to answer those questions with a subgroup analysis in patients with a low and a high ASA grade, understanding the impact of isolation in pulmonary complications in settings where other strategies to mitigate risk are in place, for instance, preoperative testing and COVID-free surgical pathways, because we could hypothesize that isolation would only be worth it in one of those settings, let's say. And also in communities where the SARS-CoV-2 prevalence was high versus low. With our sensitivity analysis, we tried to understand if there was an optimal time frame for which patients should isolate before surgery. Was it more worth it to isolate 3, 4, 7 days before surgery? So I'm going to give you the results of that in a few moments. So overall, we've included around 96,000 patients in this study from over 1,600 hospitals in 114 countries. To give you an overview of where do these patients come from, who are they? 65% of our patients came from areas where there was a high community prevalence of SARS-CoV-2, and also 67% of our patients came from high-income countries, which makes sense, of course, because we're looking at October 2020, and that was the trend all over the globe. 77% of the patients were undergoing surgery for a benign condition, and around 60% were undergoing major surgery. Just to give you an overview of which patients are we talking about. Overall, around 28% of the patients isolated before elective surgery. And when we look at their features, we know that patients who isolated before surgery were more likely to be older, to have more respiratory comorbidities, and to have a higher ASA grade. And that's important for the interpretation of our results. In terms of outcomes, the overall rate of postoperative pulmonary complications was 2%, and the overall rate of mortality was 0.7%. Of all postoperative pulmonary complications detected in this study, only 11% were in patients with a SARS-CoV-2 infection. So we would perceive that a minority were related to SARS-CoV-2 indeed. When we compare unadjusted rates of the different outcomes, we see that there is not a big difference between the pulmonary complication and the SARS-CoV-2 infection rates. There is a slight increase in the unadjusted analysis to say that mortality was higher in patients non-isolating. But then we have performed adjusted analysis to adjust for patient factors, surgery factors, and local community factors as well. And when we look at our main model for our main outcome, which is postoperative pulmonary complications, we see that patients who isolated have actually a higher rate of pulmonary complications after surgery with an odds ratio of 1.2, which means that the isolation does not seem to protect them, but actually might increase the risk of postoperative pulmonary complications. When we look at mortality, the difference that we've seen in the unadjusted rates actually disappears, and there is no proven difference in mortality when we compare patients who isolated and patients who didn't isolate. These findings were consistent across the different subgroups that we've looked at. So either isolation did not bring any benefit, or actually it increased or was associated with an increase in postoperative pulmonary complication rates in all the subgroups that we've looked at. It also, in our sensitivity analysis, we've figured that the longer the isolation period was, the higher the pulmonary complications after surgery actually were. So that trend was seen in our data as well. So just to sum up, and before opening the discussion back to you, Anil, the main key findings and messages from this paper are that preoperative isolation does not seem to bring a benefit to patients. It's associated with higher pulmonary complication rates after surgery, and that longer periods of isolation are associated with increased risk. And I will leave for everyone here to discuss how can we interpret this and how can we implement the findings of this study. A final word to say thank you to all our collaborators for taking part in this huge study. We've included more than 15,000 collaborators in this paper, which is a great achievement for the collaborative, and to all our funders for making this possible for us as well. Thank you. Over to you, Anil.
Well done, Joanna, and thanks very much for a clear study. So I think let's get to the crux of it. Let's talk about the weaknesses first, if we can, because I'm going to caveat that by saying that as far as I'm aware, this is probably the first and probably the largest study on the topic. I also caveat that we never set out to design the perfect study. What we're trying to do is shed light on the topic. So I don't think we're looking to come out with a really hard recommendation saying you have to do this for everyone. What we're trying to do is inform debate and see if people need to influence their local guidelines. So what I take from it, Joanna, and I'd be interested in your thoughts, are that the underlying rate of pulmonary complications is very similar. It's sort of 2 and 2.1%. But then when you adjust it, that shows a difference. So how do I interpret that? Small but significant, or lots of confounding? What advice can you give me?
So when we adjust for the different patient and surgery factors, we actually see an increase in the pulmonary complication rates. One could hypothesize, why are patients undergoing preoperative isolation more keen to have a pulmonary complication? And we can discuss what the reasons for that might be, and they might be related to the isolation contributing to some degree of deconditioning before surgery, which we know that can contribute to less lung expansion and more complications after surgery. There are some confounders that we might not be able to capture in this study. There might be some system related factors that we didn't capture in this study that might influence patients being more prone to pulmonary complications in one group than other, and those communities might be more using more isolation or less isolation. So there are some factors that we're probably not capturing. We've tried to adjust for all the ones we've got, but there is obviously some residual confounding being possible. And that would be my take.
So I'll ask Janet a question, please. What we don't have in this study are patients who were sort of tested positive and screened out. I do accept that, but in terms of the findings of this study, I'm struggling to see that there's a neutral side where there's no benefit. There's the possibility for a bit of harm. I can't see how we're ever going to prove any benefit from isolating. But what are your takes on whether there's a benefit from isolation we haven't seen, or whether this study suggests there is no benefit?
Well, great question. I agree with your point that this is to inform the debate, and we likely cannot be definitive at this time to say across the board that isolation does not work or is never worth it. But I think it is worth just taking a look at what we do have here. And the fact that we have a 96,000 patient strong study, biggest ever done prospectively, that has had a chance to ask this very question. And so we are only talking about associations here. So we cannot prove causation, but what we can take a look at is what we have to bolster our belief in this result, and then some of the caveats that might detract from the results. So what do we have to bolster these particular results? Well, the size of the study, right? That's one. The second is that the fact that we have a dose-response relationship. So the longer the isolation was associated with progressively increasing risk of postoperative pulmonary complications. And anytime we have a dose-response relationship in an observational study, we consider that a strength on the side of bolstering. And then thirdly, it really sort of fits with what we already know from other observational studies and some secondary analyses of randomized controlled trials of interventional studies of prehabilitation. The longer that patients are isolated or are immobilized, the more likely that they are to have evidence of deconditioning, as well as excess risk of postoperative complications, including pneumonia postoperatively. So it fits with what we already know from the pre-existing evidence base. What detracts, I'm going to add one more thing that bolsters our belief in this result. Remember that this was done in October 2020 when we had zero vaccination. And so if preoperative isolation could have made a difference, and most of the patients were coming from high COVID prevalence areas, and all of them were unvaccinated, if there was a chance for it to make a difference, this would have been the time, and there still was no proven difference. So I think all the more so now that we're in a more and more vaccinated population, routine preoperative isolation likely cannot make a routine difference in terms of postoperative pulmonary complications. Sure, we have some unresolved potential confounders that we couldn't work out in our study. We can't ever rule that out. But I think on the balance, we're on the side of bolstered our belief, given what we already know.
That's really interesting. And I think talking about, it's impossible to talk about this without talking about vaccination now, because our patients around me are coming in vaccinated for elective surgery, and they're coming in with a test. Anna, is that the same in Madrid? Are your elective patients now generally vaccinated? Are they coming in with tests preoperatively? Is that happening in Spain?
Well, yes, most people now in Spain, adults are vaccinated. Pre-operative swab is performed in routine. But I think that vaccination has not changed our performance in surgical patients yet, because we need more studies. We know that double vaccination is good, but we need to explore this in the future and see how this can change the things and the guidelines. But again, I think that the problem with preoperative isolation is that it has impact on the functional capacity of the patient. And when we have evidence from the past, we have a lot of studies talking us about the importance of multimodal rehabilitation programs to keep the functional capacity that are based on psychological, and nutritional habits. So with preoperative isolation, I think we impact on them. So it is very important, I think, that institutions establish remote multimodal rehabilitation programs to perform at home in case we consider that the patients need to be isolated. So in this sense, I think that the hospital and site must be reviewed the policies. And also it will be good in the future, probably even when the pandemic is over, because elderly people sometimes find very difficult to go to the hospital for rehabilitation programs. So we can learn a lot from this.
A quick follow-up question for Janet, just based on something Anna said. It's a tricky question. I'm just wondering if there is any evidence that a short isolation period might be bad for a patient's lungs, for example. I think our study hints at that these even 3 days might be detrimental. It makes some sense to me that a patient who is stuck within their house may move less. Are you aware of anything beyond this, or are we in sort of new territory because of the pandemic?
Right. Again, great question. I think that so in our study, the difference in terms of potential for excess postoperative pulmonary complications occurred between 4 to 7 days, and then even greater, 8 days or more. Do we have evidence that a short, 1 to 3 day period of isolation is itself associated with excess risk? We have less of that in the pre-operative setting. Most of that comes from the post-operative setting, whereby, patient immobilization post-operatively progressively increases the risk of pulmonary complications. And so hence, the idea that we should get patients up and moving. So this is sort of new territory. And so I think our study as well suggests that, at day 4 and beyond, we should be concerned about that excess risk.
Thank you. Joanna, back to the originator of this study. Again, I wonder, do you think taking together all of Covidsurg's data around testing, around cold surgical pathways, if we were to recommend that most patients stop isolating, Joanna, do you think there's a risk that a patient could bring in an asymptomatic SARS-CoV-2 into a 4-bedded elective surgical bay? Is there a risk of that? And would you judge that risk to be high or low?
Thank you, Neil. That's actually one of the questions that maybe our colleagues are asking now. So I have pre-operative testing in place. I have a COVID-free hospital where I'm working, or a COVID-free pathway in my hospital. Is it worth or not actually isolating patients? So we know that the benefits of testing and COVID-free pathways have been proved in terms of patient outcomes. Our findings were consistent regardless the presence of those strategies, but obviously those strategies mitigate the risk of an asymptomatic carrier coming into the hospital with an infection that can be then spread to other patients. This study in particular did not look at the in-hospital transmission to other patients. So there is a potential that there is no benefit to the individual, but there might be a benefit to the hospital community, if that makes sense, that we didn't capture. However, with other strategies in place, such as preoperative testing, COVID-free pathways, and now the vaccination rollout going up and up, it's less and less likely that isolation will contribute further to mitigate against that risk. I think that would be the main finding.
Yeah, I think that it's a theoretical risk, but if we look at the rates of pulmonary complications, and what's interesting about this study is the rates of SARS infections were even lower. So the chance of a vaccinated patient who's had a test coming in with a SARS-CoV-2 is actually tiny now. So I think that's a really low risk. Before we do some cases, I might just ask you all. I'll start with Anna, then Janet. My observation is that there is also a social impact of isolating patients, especially some of the older patients. Before they come into hospital, they're isolated away from their families. And I feel it most on the morning of surgery, because patients aren't allowed to, in my practice, patients are not allowed to bring anyone else in with them for the same reasons we've discussed, even if that person has been double vaccinated, is wearing a mask and has a test. So the patients are, my feeling is they're socially left slightly vulnerable. Do you see that? Do you think it's a problem, or is that overridden by the safety concern?
Well, I think that it is very important also that the patient has the family support in the moment of the surgery. So in Spain, I think that most sites allow one family member to stay with the patients. Some young patients that are going to stay for a short time in the hospital are alone, but especially elderly people, I think that it's very important to have a member to support. I think that the psychological aspect intervention, it is also very important. We cannot forget that part as part of the physical and the nutritional habits rehabilitation programs. So it is very important that the patient has the support, especially when they ask for it.
Janet, do you think we need to be taking into account the patient's social well-being, even in the COVID era?
Absolutely, and especially so. So we, in the COVID era, had to pivot and try to be in a virtually dominant environment to do our pre-op assessments and to manage patients through the pathway. And now I think this particular result from the study now should be a cause for pause, whereby we now start to think about and what are the potential harms of pre-operative isolation, which is different for every patient, but some patients are living in conditions where then they might be isolated to one room and may be cut off from social contact and may not even have technology to stay in touch. And so that can lead to, for patients who already have a very small reserve, right, in terms of mental health, as well as their expectations, their uncertainties, their fears about this surgery. They might have been canceled several times. They're kind of afraid to come into the hospital anyways. We need to rethink that. How can we stay connected with patients virtually in order to mitigate any social disconnection? And how do we also dovetail with that, ensuring that patients with a low physiologic reserve who might decondition quickly in those days of isolation, to ensure that they're moving, mobilized, that their nutrition is optimal. So pre-op optimization, I think we really need to now rethink this given these particular results in a COVID era.
Okay, what I'm going to do, I'm going to try and nail each of you down to specific answers to see if we can really change practice. And I'm going to just try and show a couple of cases. Can you see my whole screen there?
Yes.
Okay. So Joanna, we'll start with you. This is all elective surgery, and someone sent a question, Keith, which again, it's around a case. I'll come to that in a moment, Keith. But if we're doing a 47-year-old man who's got schizophrenia, but is generally well, ASA1, you want to bring them in for a laparoscopic cholecystectomy. They've got symptomatic stones, they need their operation. They've had a single dose of the vaccine, and at the moment, their community incidence is low. So let's for a moment assume that you're not going to be able to get that second dose in time. but you do have an operating slot 2 weeks away, and you do have testing. Would you isolate this patient?
Okay, so this is a very interesting case where we see that the pre-operative risk assessment would probably reveal to be quite low, and actually the procedure is not a big laparotomy. So the baseline risk for this patient to have a surgical complication or a pneumonia after surgery wouldn't be very high. In terms of the isolation that we would discuss with this patient, I would probably flag that this patient has a schizophrenia, which means that this patient might have extra benefit of keeping his social network as active as possible and the psychological support as active as possible. And also that the physical mobility and all the daily routine of this patient should be kept for things to not decompensate around surgery. So I think with a single dose of the vaccine that would give some protection to the patient with low community incidence, I would probably for this patient not recommend isolation up front. If the family would desire otherwise or wish to do something different, we could discuss, of course, and I think this needs to be case-to-case discussion. But in principle, this patient wouldn't have a huge benefit from isolating. I think that's what the data shows.
So yeah, I would be pushing for that second vaccine, but either with or without, I would be comfortable not isolating that patient. Anna, let's discuss another patient. So a 76-year-old woman who has got some comorbidities, hypertension, diabetes, COPD, currently smoking. So her ASA is a bit higher. Her ASA comes in at 3, but she's been double vaccinated. However, she's in an area where there's a high community incidence and we need to bring her in for a right hemicolectomy. So to summarize, some comorbidities, double vaccinated, some SARS in the community, right hemicolectomy. What are your thoughts around, and this is a tricky one, what are your thoughts around isolating this patient?
We have here high-risk patient. So I think we have to think of 2 crucial points. From our previous studies published in The Lancet, we know that in case of preoperative SARS-CoV infection, the mortality is high. Moreover, this patient is over 70 years old, and it is an oncological surgery, and she is higher ASA grade. So, and she's a high risk in case of SARS-CoV-2 infection. On the other hand, we have evidence that multimodal rehabilitation programs, as we have already talked about, nutritional, psychological, physical interventions, reduce postoperative complications. However, preoperative isolation could block or prevent these programs. So the answer is not easy, but I think that here we have to weigh up the pros and cons and to discuss with the patient and her family what evidence we have, what they think. It seems the patient has a high risk, so I will advise preoperative isolation, but also I will try to establish a rehabilitation program at home with family and to try that the patients has a better surgical outcomes. It is also good that she has a double vaccination, but we still need more studies to know how much relation we can have in surgical patients. Also, we have to have in mind that the incidence in the community is high. So we have to think also that with pre-operative isolation, we can reduce the number of patients that are incubating SARS-CoV-2 and are admitted. So I think that if the patient is happy with pre-operative isolation and family is happy also, I will advise pre-operative isolation, but with a remote or rehabilitation program at home to try to get the best surgical outcomes in these patients.
Thank you very much, Anna. I'll just launch a poll there because we're a bit behind on that. Can I launch the first poll, please? So this is just asking people whether their baseline is to, before you came into this, were you isolating patients? So I'd just like to launch that poll if we can, please. In the meantime, just Annie, I just want to go to Janet on your last point. You pick up a really interesting thing. What we're dealing with here is a potential unintended consequence of an intervention. So the intervention was isolating patients. We're now assessing after the intervention, sort of whether it worked or not. So if let's assume that we don't isolate these patients, Janet, and they're all double vaccinated, and we want to bring in some prehabilitation programs that may be at home and digital, is it reasonable to just implement them, to implement and test in a few years, or do we need to implement with a trial? And my thoughts are, I can't see any major unintended consequences of an exercise at home program, but I do think about the costs associated with it. So from your point of view and your expertise with evidence generation, how should we be approaching the concept of prehabilitation at home?
Right. So I think that because prehabilitation is an intervention, and because we have not actually truly figured out what is optimal in terms of the components of prehabilitation, I really think it is an area for future development. And we've made a lot of progress during the era of COVID in terms of platform-based, pragmatic clinical trials to do so, to efficiently gather evidence. And I really would encourage that we should be part of a movement to now test prehabilitation interventions and the multiple layers within, and perhaps have a flexible adaptive design in order to generate evidence efficiently around that. And yes, I think, certainly in terms of the studies that have been done around prehabilitation, the majority have been observational and have been based on surrogate outcomes. So it's really time to graduate beyond that to clinically relevant outcomes as well.
Joanna, is the concept of prehabilitation at home, is that something for elective cancer patients in North America, or is this a sort of a slightly leading question? So let's just think about the risks and the benefits and the costs, and the resources available. Is this something for well-resourced systems, or is it something for all systems?
I think there is probably a role for us to adapt the way we deliver it. So it won't be possible to do it the same way everywhere. But I believe that within the capacity that exists, in low and middle income countries, we can try to at least promote some behavioral changes for patients while they are awaiting their surgery. And that can be promoted by surgeons themselves or by nurses who see the patients in the preoperative setting. And those things can be communicated to families in low and middle income countries as well. If we can develop slightly well-resourced programs in high-income countries to try and find the most efficient and cost-effective way to do that, that can then be maybe tested and also translated, and global trials or studies can be done to see if it's applicable elsewhere. So I think it's, in practical terms, we need to adapt, but where it's possible, we need to do it to generate evidence so we can move forward?
I think in terms of, I'll ask you all for a quick answer in this. And I think the second poll popped up, which is asking, what length of time you are isolating for. We can probably have the last poll as well, please. So I'll just do these results. Interestingly, the majority, about 70% of people are self-isolating, are telling their patients to self-isolate before surgery. So 70% of people coming into this. We've then got a second poll and a third poll to flash up. And my question is this: who would we keep isolating? And I think that the hardest part in my mind are the older, frail patients with more advanced respiratory disease, because one part of me wants to protect them from what's going on in the supermarkets and protect them from even their families, get them vaccinated and tell them to shut down in the house. But the evidence makes me concerned that is that the safest thing to do? Not everyone is blessed with a large garden in which they can exercise. So can we just consider this type of patient for a moment? An older patient who is frail, facing a lung or abdominal operation, and the community rates are simmering away. My interpretation of this evidence, and I do stress interpretation because I think everyone will address this differently, is that in presence of, if they were double vaccinated, this is how I would approach it. So major surgery with risks, double vaccinated. I know I can test them. I know I can bring them into a COVID-free pathway where they're not going to be surrounded by other COVID patients. So a colder area, a colder hospital. Under those circumstances, I would be encouraging my patient not to isolate, as long as that's in keeping with local guidelines. I would hope my guidelines would support them not isolate. I wouldn't advise anyone to break the guidelines. What I'm saying is that's how I'd be approaching it from a guideline point of view. I think if the patient didn't have one of those factors going their way, I would probably isolate them. So if I had to bring them into a hot hospital, where I know they're going to be rubbing shoulders with patients who have only just had a test, who are unvaccinated, who are SARS-CoV-2 positive, then I probably would, I'd be approaching this all slightly differently. So Janet, Anna, and then Joanna, is there anyone you would be advising to isolate?
I think it's the simplest thing to say that it's a patient-clinician shared decision-making issue. And suffice it to say that I can't say I would never recommend to isolate a patient. There are some higher risk patients who are also in a situation where they can be well supported in their isolation, for which, they've got family or caregivers who are going to take care of them, who are going to make sure they mobilize, or they're virtually connected, okay? And they're not at the edge in terms of physiologic reserve that I'm concerned about them deteriorating in this isolation period. But on the other end of the spectrum, I'm agreeing with you that I don't think we should, in our guidelines, recommend routine preoperative isolation for our patients, because this is the largest study ever done that has dared to ask this question. And even if we interpret this conservatively and say, well, there is, say, at least we didn't prove that there is a benefit in any subgroup, then I don't think we can routinely require this. And perhaps there is even a risk with increasing days of isolation, okay? And so potentially with that excess risk, I think that now begs us to reconsider, what does our prehabilitation look like? What does our connection with patients and ensuring their social, nutritional, and mobility support look like? And make this on a case-by-case basis. I also, though, would want to clarify that we're not advocating for carelessness in terms of patient exposure to SARS-CoV-2 in the preoperative period. I think the general sentiment during the time that this study was done, that we should be take very great care in our preoperative assessment and recommendations for patients. And so even those who might not have said in our prospective study that they isolated, they still might have been taking great care in terms of public health and infection prevention control strategies to reduce and mitigate any exposures to COVID prior to surgery, because most patients, again, would fear that as part of their care pathway. If I could,
yeah, please, yes, sir.
If I could just add one more layer, the thing that we haven't talked about today is that we are also interested in benefits to the system of not having COVID enter our surgical and perioperative pathway. Very important. But there's another benefit to the system of loosening the requirements for preoperative isolation. And that is the fact that it just simplifies our preoperative care planning and our ability to schedule patients in for their elective surgery with more flexibility on the timing of when that surgery would occur, inserting them, on open, in the wait list, or if something comes open, without requiring this preoperative isolation period. It certainly helps us simplify in terms of now clearing our backlogs. Clearing backlogs is probably our biggest concern in terms of a system benefit. And I think that is something that we also shouldn't forget as a potential benefit of this loosened recommendation.
No, I agree. And that's part of the Covidsurg story. And we're now looking to restart surgery and help people support in that. Anna, can I ask you in our last few minutes, how that older patient with lots of comorbidities but they're vaccinated, would you be looking to, would you recommend they're isolated or not? And just before we do that, I'm just going to have a look at the results of the last poll. So it's interesting, so about half of people, just over half, will probably move away from slightly harder restrictions to slightly easier restrictions. And I think that's what we've been talking about today. I don't think I've heard anyone say they're going to, force everyone to go into the park. I think we're going to start to ease things off and probably reassess. That's the other thing we haven't spoken about, probably reassess what's happening and then take another step. So that's very interesting poll results. We'll share those via Twitter later. Anna, so the higher risk patient, would you be looking to isolate them or not?
Well, according to our research in these studies, there was no difference for high and low risk patients. So we should not recommend preoperative isolation. But I think that we cannot forget other aspects that we have learned from previous studies in Covidsurg. We have learned the role of preoperative swab testing and COVID-19 free surgical pathway. So I think that both of them demonstrated that a reduced postoperative pulmonary complication. So I think that if we use and we have implemented them, the patient is a high-risk patient, it is agreed not to go to isolation, and we can not recommend isolation. I think that the question now is to change the concept, not to recommend isolation in general, but to select what patient should be isolated, and probably the number should be a very low number. And also, I think it is important for high-risk patients to discuss with them and that they are involved in the decision in active way together with their family. I think it is very important.
Thank you very much. Joanna, last point just before we wrap up. So let's say we're going to make a change, which is lightening of restrictions and isolation. That's combined with more vaccinations. And the other thing I take from this study is that viral pneumonias that are perhaps non-SARS are going to be the problem. when I combine that with the fact that our last SAGE, which is our scientific advisory board in the UK, they've said that the main threat going forward for the next few years is going to be new variants, and these vaccine-resistant new variants are going to become an issue. Is there a role for us and the collaborators watching today to suggest what a data collection study in 2022 should look like? Or have we got all the data we need now?
I suppose there is always more and more research questions, and it's great to be part of this platform that is now set up to answer nearly any question in the world. So we could look at which are the most efficient ways to make prehabilitation agile from home when, for instance, new variants come up in a particular country or in a particular setting, or when rates simply go high and the testing capacity might not be great in some settings. So communicating these risks to patients will be very important. So we can look at vaccination, testing, COVID-free pathways, isolation strategies, and combinations of those to mitigate risk, because we've looked at them separately. So there are definitely a few other things we could do in the future, and I guess the Clarity is up for it.
Thank you very much. So just a quick look to the future. Later in August, we are going to be launching our paper in the Anesthesia Journal on VTEs and SARS-CoV-2 positive surgical patients. We have discussed that before, but you will see that coming out. We are also going to be launching our cancer paper shortly. And a lot of this will be coming through our surgery2025.com platform, which is where you can gain your CPD certificate. So we are trying to release more data. And there's another paper that we are in the processes of developing, which will be looking at the higher risk surgical patients and whether they can be safely managed outside of a critical care unit. So that's going to be really interesting, because again, that's going to help us restart routine surgery for higher risk patients elsewhere, outside of the big hospitals that are clogged full of, clogged is the wrong word, that are busy dealing with patients with acute needs from the community. So there's still data coming out. Please stay tuned to all of our social medias where you'll see it. Anna, Joanna, and Janet, thank you very much for joining me. That's quite a robust discussion. I think it's a really tough area, actually. In interpreting and implementing this data is what we're all about, really. So thank you very much for joining us. And we'll leave it there. So please keep an eye out for our next webinars and our eye out for our next papers. And thank you all very much.
Thank you.
Thank you so much.